Hello everyone. So we have a 7-year-old boy brought to the emergency department due to abdominal pain, fatigue. He developed abdominal pain, vomiting and diarrhea a week ago. Few days later, he noticed significant blood in the diarrhea, which is now resolved. His mother believed that patient was improving until he developed diffuse abdominal pain today and did not went to get off the couch. Despite drinking a normal amount, he has not urinated in last 24 hours. Multiple family members had similar initial GIT symptom after attending a family cookout last week. But the mother says that everyone else is recovered, but only except this child. And on examination, stellar icters, diffuse abdominal tenderness, and +2 pedal edema are present. Well, which of the following lab finding more likely to be seen in this patient? Well, the answer to this question is option B, decreased platelet count. Well, this is a case of hemolytic uremic syndrome, what you write as HUS. So before I discuss the question, let me tell you some basic concept about hemolytic uremic syndrome. Basics. Initial insult from Shiga toxin, most commonly E. coli strain O157H7 strain, and that lead to vascular damage and microthrombi formation. The usual clinical picture: antecedent diarrheal illness, often bloody, microangiopathic hemolytic anemia that lead to fatigue, pallor, and schistocytes, thrombocytopenia that lead to bruising or petechiae, acute renal injury, oliguria, and that can lead to edema. Now, having learned the basic concept, let's come to our question. Our patient 7-year HUS usually occurs in children. This is such an important point to talk because a similar disease TTP, it occurs in the adults or middle age, and this is in children like 7-year. And in our patient has abdominal pain, fatigue, decreased urination. He has not urinated in the last 24 hours. And this usually occurs after bloody diarrhea illness, what happened in our case also, which is concerning for hemolytic uremic syndrome. He noticed significant blood in the diarrhea. And now it occurs by which toxin? Stop the video, write down the answer. It occurs by Shiga toxin. And I told you this occurs by strain of E. coli. This toxin initially invade and destroy the colonic epithelial lining, and that produces bloody diarrhea and abdominal pain. So Shiga toxin is the key word to remember in this, and this is it comes from E. coli, which strain this you should know. 15% of the patient only they develop classical triad. Triad is microangiopathic hemolytic anemia. What we got in our patient: thrombocytopenia and acute kidney injury, poor urine, edema, elevated creatine, blood urea, nitrogen. So in our patient, all three things are there. But remember, the classical triad seen only in 15% cases, not in every case. Schistocytes, you can see lovely schistocytes are there. Okay. So-called helmet cell, also known as helmet cell. And this can be seen in any case of MAHs, microangiopathic hemolytic anemia. Well, pathophysiology begins with a systemic vascular endothelial injury. Subsequent platelet microthrombi formation occurs. It leads to thrombocytopenia and schistocytes they flow through the small vessel, including glomeruli. This results in intravascular hemolytic anemia, leads to decreased haptoglobin. Option E is increased haptoglobin. But in our case, it is reduced haptoglobin occurs. Elevated bilirubin causes scalar icterus and jaundice. Treatment is supportive. fluid electrolyte management, transfusion, and dialysis, only all supportive. Let's look into other option. Decrease ferritin level. This is seen in iron deficiency anemia. While in case of HUS, ferritin level should be normal or increase because it is the acute phase reactant also. In acute phase reactant, ferritin level rises, but decreased ferritin level is not a feature of HUS. What about decreased reticulocyte count? Well, in this case, this will happen in the setting of defective bone marrow, viral suppression, aplastic anemia, malignancy. Retic count are increased in hemolytic anemias. Always. This cannot be the finding. Prothrombin time coagulation profile is normal. There is no problem. Of course, thrombocytopenia and microangiopathic hemoleutemia can be seen in both HUS and DIC. But in DIC, abnormal coagulation profile occurs. But coagulation profile is normal. Clotting time, PT, PTT are normal in these cases. Now, again, I have a question for you. Write down the answers, stop the video. In which type of AML DIC occurs? Well, it's an easy question. Answer is M3 variety. Golden line to remember, hemolytic uremic syndrome, most commonly caused by Shiga toxin produced by E. coli strain 0157H7, characterized by microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. This is the classical triad of a case of hemolytic uremic syndrome, which is a disease of children. Thank you very much.